Again, I am talking about lot of loss of function variant. What about gain of function? Gain of function are really very rare, and even if we find one thing which is gain of function, which is protective, it is very difficult to actually treat, develop a molecule. Usually, it is you have to go either for gene therapies or protein engineering. So far, in the documented evidence, there is only one medicine which is approved some 4 years back, which is for cystic fibrosis. This is the first medicine. This is actually a molecule which enhances the chloride channel. So this is the only medicine available right now. I don't know how many billions of dollars it took for them to develop that medicine, but usually we are not interested in gain of function because of utility. So how do we identify? How do we identify? So this is where the importance of gathering a meaningful data comes into play. It is not just we have the genomic data and we don't have a very quality phenotypic data. Phenotypic data means we need to know exactly all the lifestyle history, all the family history, all the BMIs, all the biochemical markers, and not just at one cross section, but continuously over time. So, for example, in genomic medicine, it is always difficult when I was talking about this one. How do you say that you are a case and you are a control? Control meaning you don't have the disease. So, for example, I do a blood test on a guy who is 25-year-old, and I find that he does not have diabetes because he's 25. He does not have diabetes. How can I say he will not develop diabetes in 20 years? How can I say he is the control? So that is the reason why this long-term thing. So the definitions when it comes to cases and controls in genomic medicine is completely different from the regular clinical practice. So there are no guidelines yet, but people are coming up with guidelines. What is the control for diabetes in genomics is a 55-year-old and above with HbA1c of less than 5.5, preferably obese, not even lean, obese, less than 5.5, and I would rather even put in, if we want have a control for coronary disease, I want a 60-year-old male who is a smoker, obese, bad lifestyle, but no disease, zero coronary. That is the control that I want. I want to see what is the genetic variant in his body which is protecting him from having the disease. So these are the people that once we gather over time and collect, that is when we are going to have the controls. So this is the bioinformatics pipeline, how we annotate, how do we define a loss of function variant with high confidence. Okay, this is a variant which is present in this guy. When we compare it with the reference genome, it is showing that this is a significant mutation, which is most likely stop gain. And then this is the high confidence loss. And we accumulate all this data into adding in the phenotypic data into it. What is his family history, what is his age, what is his socioeconomic status, what is his smoking status, what is his alcoholism, what is his societal status, and what is his marital status, what is his fertility status, and so on. So there will be almost 650 questionnaires that we go into in detail to identify what are the phenotypic characteristics of this person, and then we do the repeat questionnaire every year, and then we also do the biochemical analysis every 3 years. So this is the usual process. How do we validate the association? The first part is easy. There is population studies, which is global data, which is billions of articles present in PubMed. So we do an complete RAG-based model to identify this one. I will briefly go over it. So case control studies, we have established frequencies of this in the population, and then we identify those. And the second one, what we are trying to develop is test whether the carriers of this variant show favorable phenotypic traits. So he does not have the disease, lower disease markers, biophysiological benefits. So this is A and B are the ones that A can be done easily, B that we are doing. C is the extreme cost of, what do you say, just for the C, in vitro assess and animal models. This will cost almost 10 to 15 million for each variant to validate. So this is where the pharma companies come in, and this is where most of the validations and R&Ds go, and association studies. So where does the AI fit in all these models? So AI fits in every step of this model. How we gather the data, how we store the data, how we use the technology about the disease pathology, the pathophysiology of the disease, and the pathway of the gene. All these things come into play once we get the whole data into one integrated database.